Good afternoon and welcome to Your Next Move with Managing Monkeypox and Polio Endemics. My name is Autumn Brennan and I'm honored to be Axiom Medical's Communications Director. And today I am joined by two passionate thought leaders, Axiom Medical's own Mark Robinson, our CEO, and Chief Medical Officer, Dr. Scott Cherry. Welcome, Mark. Please feel free to introduce yourself.
Hi, thank you. My name is Mark Robinson. I've had the honor and the privilege of being the CEO here at Axiom Medical for the last 6.5 years. A wonderful journey on a mission-driven business that seeks to help workers with health challenges in the workplace. So it's a interesting and somewhat stressful time for us all to live, with a lot of relatively previously uncommon disease and other related issues to deal with in the workplace. And what we're trying to do is help shine a light and provide a beacon that will allow employers to think about how to respond to these challenges in an ethical and appropriate way.
Absolutely. Thank you for that. And next, we'll meet our Chief Medical Officer, Dr. Scott Cherry. Please introduce yourself.
Good afternoon, everyone. My name is Scott Cherry. I'm Axiom Medical's Chief Medical Officer for the past 4 years. My professional background, I'm a board-certified preventive medicine and public health physician. I'm also certified in occupational and environmental medicine. And I've spent my career supporting populations of employees in the U.S. military, corporate and industrial operations. And it's a pleasure to be here with you today.
Thank you. So today we'll be breaking down the basics of each of these illnesses. So Dr. Cherry will have you covering that, starting with the history, symptoms, and some treatments, then taking a deeper dive in how this affects us all in the workplace and best practices for building a resilient and healthy workforce. So resilience is the key here. We'll also be answering some questions about how to manage contagious illness outbreaks in the workplace and how they interfere with our productivity and affect our culture. So let's jump right in and start with the why.
Yeah, I'll take the first stab at that. So throughout human history, we've been exposed to new diseases and outbreaks of known diseases. And those outbreaks and the new diseases vary significantly in severity, both initially and their impact on us over time. And that hasn't really changed very much. But what has been changing is the virtual size of our world. We have 7+ billion people on the planet now. We have rapid travel between every destination on Earth, practically. We have a lot more mobility in populations, and we live in closer and closer proximity to wild creatures. And so if you look at what's happening, we're seeing more diseases cross species barriers than had been the case in the past. AIDS was the first one that became something we knew widely, but there are others, and there's a lot of speculation about the origin of COVID, but there's a clear common genetic thread between this variant of the SARS-CoV-2 virus that we've seen and a virus that is prevalent in bat populations. So we're likely to see more transspecial diseases as we go through the coming years. We're also at a point where barriers that had enabled fully vaccinated populations to stay safe have begun to fall away. So we're seeing in the US a resurgence in multiple diseases. Tuberculosis has been one that's gotten a lot of press over the course of the last couple of years, and rightfully so, because it's a horrible disease, and polio. And in both cases, it's travel between populations that is the primary vector by which these diseases are reintroduced to the United States. And then on top of that, we've seen a rise in vaccine skepticism, something that I struggle a little to understand, although I think it's connected to a general distrust of government that has become more prevalent in in our world over the last decade or so, and a rising distrust in medical institutions as well as the kind of morally virtuous guides that certainly when I was growing up, that's how we regarded doctors and medicine. And so these diseases like polio that we'll talk about, where if you went back 30 years, we would have had probably 100% vaccination rate in the United States. We now, in the areas where the outbreaks are occurring, only have about a 60% vaccination rate, which provides a large pool of potentially infectable people that we have to look at as a reservoir for the disease to grow and spread. So those are the really big whys: social change, population change, and new diseases crossing species barriers. Scott.
Yeah, the one thing I would add is, in short, the way I've seen it is we have a mix of the evolution of some of these viruses, which have kind of been somewhat been warned by some of the public health agencies or think tanks and national security that viruses can be some of the largest risks to our civilization. And then, like you said, Mark, that our world is shrinking, so there's so much worldwide travel. But probably a third component is, I would say, human complacency in some degree with, like you said, the vaccination. And I think COVID has kind of clouded the term with regard to being against vaccinations. And I kind of see it in two ways. There's a view of, but before COVID and COVID vaccinations, there was a group of people against kind of the standard vaccines out there. And now we have, some skepticism towards the COVID vaccine. But regardless, what employers really need to focus on is maintaining continuity of operations. And so, a decade ago, I think there was strong lines between personal health and employee health, or the employer's responsibility for different occupational medicine programs. But I think that line is being blurred, and a paradigm shift is occurring to where employers are needing to make sure they have the appropriate level of staffing to get the job done in their respective industries. And I think employees now are more and more sensitive to workplace risk from their coworkers or from the public that they may be serving. And so employers are being held to a higher standard than what maybe the CDC is advising to the general public.
Absolutely. Can you tell us how these infectious diseases are affecting employers already struggling with COVID-19?
I would say in many ways, there's been a struggle for adequate staffing to, really get enough human capital to get people in new roles or to maintain their current staffing. So that's quite a challenge in many ways for employers. And as new threats become apparent, I think that further creates challenges for these employers to, hire and retain the best talent out there. Mark, do you have any thoughts?
Yeah, I do. I think it's also everybody's seeing everything through the lens of COVID right now, right? And that's been our singular experience for the last couple of years. And not all diseases are COVID. All infectious diseases are cause for appropriate caution in dealing with them. And some are very relevant to the workplace, and some may be less relevant to the workplace. And employers are struggling to figure out which are which, what set of responses are appropriate to which disease. And in fact, given the slackening of social pressure and regulatory pressure on COVID management in the workplace that's occurred over the course of the last few months, they're actually almost desperately hoping that there isn't another disease that they have to deal with. And I think what we're going to try and do today is show that there's a rational approach that is available to be taken to assess risk in the workplace, and to create differentiated strategies for management in the workplace for different diseases.
Absolutely. I think resilience is key here. Many of our cultures are just tired. We're tired of all the changes. We're tired of the protocols. We're tired of being away from each other. So I think anything we can do to build resilience to change and have resilience and capacity for the next big thing that comes is a gift we can give to our cultures and managing that.
That's very true, Autumn, but employers specifically need to be aware that being tired doesn't excuse them from their obligations.
True. Very
right?
true. Thank you for that.
And cultural resistance from their workforce doesn't excuse them from the obligation to comply with general duty clause from OSHA, for example, which requires them to take all reasonable measures to exclude infectious diseases and infection generally, anything that can injure an employee, to exclude those from the work environment. So this is all really a case of figuring out a path to navigate through all these competing influences and finding a way to be compliant with both the ethical and moral obligations that you assume as an employer and the legal framework within which you operate.
Absolutely. I really appreciate this educational approach. I think it's very empowering to not only employers, but to their employees. So let's jump right in and let's admit that we all thought polio was a thing of the past. Can you shed some light on the history of polio, Dr. Cherry?
Sure. You know, just looking at what polio is it's a virus that really infects our gut or our GI tract, and it really has an affinity for our nerves. So you really have this, I would say, perfect storm where this infection will infect our gut, and then as it spreads through our bloodstream, it will start infecting our nerves. And what's really scary about polio is that it can actually retrograde into our central nervous system. So, you know, our brain and spine are highly protected through what's called a blood-brain barrier, to where what's in our body, we may have an infection even in our blood, but it really does not get access to our brain and our spinal fluid and our spine. However, polio is quite sneaky, to where it infects our gut, but then can quickly get access to our central nervous system. And so obviously, I think historically we've seen cases of paralysis from polio. About 95% of cases are actually asymptomatic or quite mild. And so only about 5% of cases actually have paralysis or severe symptoms. So here in this chart, you'll see that, you know, polio virus was kind of endemic and causing more and more disease in the 1950s, and really spiked up pretty high in the 1960s. Fortunately, there was 2 vaccines that came out in the 50s and 60s that really helped create a huge decrease in infections. And so in the late 70s, early 80s, polio was really essentially eradicated in the United States. And otherwise, you were seeing up to 50,000 cases of symptomatic polio yearly, which is quite huge.
I remember, I'm probably a bit older than the average audience member today. I'm in my early 60s. I was born in 1960, and I remember everybody knew somebody who at least had leg calipers or was wheelchair bound from polio. And in the early 60s in the UK, there was an outbreak that I think caused somewhere around 29,000 cases, symptomatic cases in one outbreak. And that really gave impetus to the vaccination drive in the UK. It resulted in all school children being vaccinated either prior to attending school or as part of the in-school vaccination programs that were developed back then. But Scott, there are two different kinds of vaccination, right? There is the live vaccine, typically a liquid. In my case, it was a little blue dot that was given to me on a sugar cube. And then there is and so that's an oral vaccine. And then there's a more recently developed vaccine that perhaps carries a little less risk of transmission with it. Could you talk a little about those?
Sure. So there's, again, the oral polio vaccine, which has the ability to actually generate what we call vaccine-derived infections. And so that can be a source of a lot of the infections that we're seeing potentially now. And the injectable polio vaccine actually is not a live virus, so it actually has no risk of becoming reviralizing and becoming potent to create disease. So a lot of developing countries will still have the oral polio vaccine. In fact, there's probably only 3 countries that were considered not fully eradicated. I believe it was Pakistan, Afghanistan, and one other that's escaping me at this point. But I think some of the case we have in the U.S. was travel or exposure from someone who was vaccinated with the oral polio vaccine.
A friend of mine likened it to, gave this analogy. You can pull the teeth from a snake, and that snake will never poison you, but its children can poison you, right? And that's kind of like that reviralization across multiple generations of replication, that the oral vaccine weak version of the virus can become strong again.
Exactly.
That's great information. Now let's talk about how we can protect ourselves in the workplace.
So when we think of polio, there's really no good or effective treatment options. So once you're infected and once you have symptomatic disease, the only treatment is really supportive. So thankfully, the majority of infections are asymptomatic. But if you become symptomatic, you essentially can only get supportive measures. And when it becomes involved into your central nervous system, you do see paralysis or muscle weakness. So really, the way forward is primary prevention of this. So using vaccines to ensure that you're protected. I think with COVID, people became very focused on effectiveness and safety and all that. But for polio, this is really, both vaccines are quite well established over 50, 70 years ago now. The injectable polio virus is only licensed now in the US, but for those who are not vaccinated, really the way forward is to get vaccinated as soon as possible. And so that's, I think, the miracle of vaccination, where you have a very safe and very highly effective vaccine that prevents catastrophic disease. When we look at testing, you essentially don't know you're infected until you become quite symptomatic. The usual presentation would be you have meningitis, which is like a severe headache and a stiff neck, and then you're starting to feel weak, which really is a bad sign. And obviously this is a childhood vaccine, so children are susceptible if they're not vaccinated, but adults are actually more susceptible than children for the paralytic disease. So most adults are probably vaccinated, but now that comes into question, it's really important to make sure you do have that vaccination on board.
Dr. Cherry, do you think we're back to mask mandates or any other similar regulations, a booster or anything like that?
So I don't think mask mandates, I don't think there's been strong evidence that this is respiratory borne for polio, at least. And I think for school, elementary school, junior high, high school, for at least public schools, it's been a requirement to have polio vaccination. But, to be truthful, I haven't had visibility on that for a few decades, but I think just assuming you're vaccinated may not be the right assumption, especially with the risk benefit of not actually being vaccinated. So, I think even for workplaces, it may be great to have an educational campaign for employees who, for them and their families, right? Because our workplace is a second family, and so it would foster that kind of some of my experiences in occupational medicine was when employees came to the clinic, I was their only access to medical care. A lot of times they did not use their primary care doctor, so it's quite interesting to see that. So the employer can be a foster of education, especially during extreme times of an outbreak.
A couple of other quick points on that topic. So the primary vector is oral fecal, right? So it's contamination with feces, either from a hand or from food potentially, or dirty dishware, or a variety of sources. The number one thing you can do to reduce your risk is to wash your hands really well, really thoroughly, really often, which, as we've learned through COVID, is an important hygiene measure that we should all take on a regular basis anyway. And then the second thing that I would say is there are certain industries where there is higher risk. So right now, if you were in the waste management industry, particularly a sewerage worker, or a wastewater processing worker, or a septic pumping worker, you probably have a little more risk. And you probably need to be thinking with your employer about specific strategies to minimize that risk.
Mm-hmm.
Absolutely. Along with some of those roles that involve international travel, we need to be cognizant of that as well.
Always. Unfortunately, the world doesn't have equity when it comes to protection from disease.
Very true.
And social conditions in many places in the world are very conducive to the spread of contagious illness. And a simple lack of caution while traveling can, in fact, expose you, who possibly don't even have the kinds of native immunity that local populations have, can expose you to the risk of serious illness. So thoughtful care, pre-travel vaccination, and a watchful waiting when you get home from travel to make sure that you're not displaying unexpected or challenging symptoms.
Dr. Cherry, is there any testing involved for this yet?
No, there isn't. So that's really the trouble, right? It's you're going to present kind of late stage of this disease progress. So, if you get infected, you're going to have just generalized symptoms of like the flu or a cold, where you have fever, chills, fatigue, malaise. You just feel kind of sick, and so that's kind of troubling, right? There's not a great kind of early warning signs to get, so the test really is they'll do kind of like a spinal tap to look for the cause of the meningitis. And then they can look for other very specific laboratory values of that spinal fluid. But again, it's very late stage. So for our population here, it's really primary prevention through vaccination and hygiene measures.
Thank you for that. So now let's swing over to monkeypox. Most of us had never heard of this 3 months ago, and now it's all over the news. Dr. Cherry, please enlighten us.
So monkeypox is also a virus infection, really kind of started to be noticed early in the 1970s. It's a virus related to smallpox and cowpox, which are much more famous. Smallpox is really a devastating viral infection that is actually respiratory borne and can really cause a lot of issues. And that was actually the cause of a lot of work that actually created one of the earliest vaccines. In fact, the smallpox vaccine was relatively unsafe. And so they used kind of a sister to smallpox called cowpox or vaccinia. And so it gave you the protectiveness from smallpox, but without the risk of actually getting infected with smallpox. And so some trivia is cowpox is called vaccinia, and that's where the word vaccine comes from. It's one of the first vaccines out there. But getting back to monkeypox, really this is a disease that's highlighted by a pustular rash. And so it really was endemic in Central and Western Africa, and really was seen in small animals of forest like rodents, monkeys, and just small animals like that. And really it was relatively a quiet disease where it was self-limiting for most infections. The Central African, there's two families of disease, but the Central African one actually had about a 10% mortality or chance of death with infection. So that's quite high for that, whereas the West African family of the virus had essentially no deaths from that disease. But there have been some just to give you some viewpoint, because we all have kind of been experiencing COVID in very large numbers. So between 1970 and 1980, there was only about 59 cases in total over that decade. So really small numbers. And again, that's transmission from exposure to small forest animals. But in the 2000s, there was about a 20x increase in infections in Africa. And so, again, I think this was off the radar for most people, especially in developed countries. But, now we see this outbreak in this year in Europe and North America, to where the World Health Organization has declared this a public health emergency. And so the history is quite small, but we're seeing a huge increase in cases. Now, when you're infected, it's kind of this same kind of picture where you have just generalized symptoms of fever, chills, and it's really until you develop these pustular rash that you will have a higher suspicion of a pox-like infection. And so with transmission in the 70s and in the 2000s, primarily it was exposure to forest animals, small forest animals. Now we're seeing with this current outbreak, really it's close contact with human to human versus animal to human. And so, there's, well, I'll leave it at that, Autumn, and let me know if you'd like me to address anything else.
For sure. So I appreciate you talking about the transmissibility piece of it. It makes me concerned thinking about small children going back to school and how handsy they are. Are there any current, tell me about the current treatment and testing for it. My understanding is that it's a swab of those pustules and then those are sent in. I don't know how equitable that is, if every hospital or every laboratory has access to that testing and potential vaccines. Can you speak to that a little bit?
Sure. So I think a lot of people now have heard of the PCR test. So you once you do have these classic lesions, there will be fluid sampled and sent in for special tests to make sure, or to have that confirmatory test. In many ways, you could almost have this as a clinical diagnosis where someone may have been exposed to someone else with monkeypox. They may not know as well, but really it's almost can be a clinical diagnosis. So what's interesting is that the primary prevention for this, just like polio, would be having vaccination, which comes from that cowpox or smallpox vaccine that we were talking about earlier. So, smallpox was eradicated also probably around the 1980s. And so there was this decrease in smallpox vaccination. So people are at higher risk now for monkeypox. And so, there are potentially higher risk populations And so right now, the recommendation would be if you are part of certain high-risk populations that you do get vaccination.
Can I chime in with a couple of comments?
Of course.
The scale of the current outbreak is way, way, way beyond anything that's ever been seen before for monkeypox. In fact, we have more cases over the last 3 months than in the entire history of the disease as it's been recorded in the past. Not a very deeply studied disease, not a huge amount of knowledge about it, because risk was so low that virologists were not very interested in it. So we are still learning a lot as we go on this disease. So that's the first point I'd make. The second point is that although we think we know how it's mainly transmitted, which is intimate skin contact or contact through heavily overexposed clothing as primary vectors, we actually can't account for all cases that way. There's a small fraction of cases that have occurred in the US where the conclusion would be that there's some kind of community spread, right? Now, not validated yet. It's pretty early. There's some thought that those little globules of moisture that we all expel all the time through respiration could potentially be a transmission vector, particularly if you're really in somebody's face, in their space in their face, right? There's some speculation about that, but we just don't know enough. On the last slide, or on the last topic here, we talked about myths, and there's one that really concerns me. And it's because I'm old. So I remember smallpox being declared eradicated in the 70s in most of the Western world. But the thing that concerns me is another epidemic that I remember that came to top of mind in the 80s, and that's HIV. And the mistake that we made with HIV was characterizing it as a disease of gay men, when in fact it's nothing of the sort. That was just an easy way for transmission to occur. And because we made that mistake, it broke out from those communities where it first presented and became actually a broadly sexually transmitted disease. HIV is really hard to pass along compared to many other diseases. Monkeypox is a lot easier to pass along through contact, right? But I'm concerned that we don't make the same mistake and characterize one demographic of our population as at risk, because it means we won't think it's us if we are not a member of that population. And it also means that that population risks being stigmatized. And both of those, in my opinion, would be really bad outcomes. So we need to focus on this as a primarily contact transmitted disease. That, you know, there are the usual kinds of measures you can take, one of which is don't rub up against somebody else's skin if they have a rash or pustules present. Another one of which is good hygiene, as always, right? Another one of which is consider vaccination if you're at high risk. And again, there are certain industries where there are regulatory restraints that would make this disease something that employers have a specific obligation to work to prevent.
I recently read about a case of a heterosexual woman who worked as a gas station attendant and contracted monkeypox from handling the cash. And she has been isolated for almost a month from her child.
And there's been some pediatric transmission as well, with no evidence of any sexual activity, thank God. And so, you know, these are strong indicators that we don't have a full handle on the transmission vectors.
Yeah, I think you
go ahead.
I think you made a great point, Mark, where it's so understudied because it was such a small disease, small impact previous to this latest outbreak. I know we were talking earlier this morning, and I know you had advised me that I think every state in the U.S. now has at least a case. And so that's, you know, pretty impressive from a concerning view. And you're right. I think right now the biggest, where the light is being shown on the public health is this direct, intimate contact. But that's maybe where all the resources are being put as well. But I think over time we will understand more about transmission, and because it is part of this other, it's so related to smallpox. Smallpox is actually a droplet. Transmitted as well, respiratory droplet. And so I know there are a percentage of cases that are not well defined on how those cases were infected. And so we may get more and more clarity about transmission, but I would not rule respiratory or respiratory droplet borne out at this point.
One final point on this. This isn't like COVID, where we get into the hundreds of thousands of cases transmitted a day. And it's really hard to conceive that we would get to that, right? But still, in terms of its epidemiological profile in the US, we went from near zero cases 4 months ago to 50 states. And the last number I saw, I think maybe a month ago, was 10 or 12,000 cases, probably 20,000 cases now. So it is something that every employer and every human should have on their radar, not fearfully, but be sensibly watching and learning information as it becomes available.
Absolutely. Dr. Cherry, do we know anything about the long-term health impacts of monkeypox?
I think what we know is, fortunately, with this form, it's almost a third kind of clade or family of this species of monkeypox, at least in the US, has no fatalities. So we know, at least on the severe side, I know that the lesions or the sores can be exquisitely painful, and some people are actually admitted just for pain medicine to the hospital. I think it's to be determined if there's long-term scarring, or a lot of times with these viruses that infect nerves, you have a lot of nerve pain that can be chronic. I think people can relate to maybe shingles, which is a form of chickenpox as an adult. And I know that can be quite painful, but I'm not sure about anything else at this point. One thing I would like to add that I think is probably more of the trend we're going to start seeing with infections in the workplace, or at least how the world is focusing on infectious disease post-COVID. The early analysis of this outbreak of monkeypox shows a tremendous number of mutations compared to the stable previous 2 clades of the virus. So it is interesting to see that, I know for COVID, we're used to seeing mutations and variants and subvariants, but a lot of viruses do not have mutations. A lot of times it's dependent if they're an RNA virus or a DNA virus. The RNAs are much more predisposed to mutations based on how they don't really have proofreading in their replication cycle. But this is definitely another sign that public health agencies really need to keep the eye on medical surveillance as best they can.
Absolutely. Dr. Cherry, have you read anything about antiviral medications and how effective they are with monkeypox?
I'm not aware of anything of relatively effective. I'm sure they're trying many different things, maybe off-label, but I'm not aware of any indication for. It's a lot like polio in the sense, once you're symptomatic, it's largely supportive.
Just one final quick point. Symptoms can prevail for quite a long time.
Right.
I mean, it would not be unusual for you to need a month to be fully asymptomatic, having begun to have symptoms. And obviously that's a period of time during which you could not go to work, right? And you should stay away from other people or avoid contact with other people to the greatest that you can reasonably do in order to avoid passing it along. So the window of time during which you can infect people is much longer than it is for the other diseases we've talked about today.
And that's a great reason to have definitive or confirmatory testing, because it gives you an idea of what the employee or the patient can expect. One, just their own illness, but two, about return to work and engagement into the public, or even your family, right? Like I am aware of some infections with children are it's through just caregiving. And so it is an important feature to have an accurate diagnosis.
Absolutely. All right, let's talk about best practices a little bit. So we know to wash our hands. We know to stay away from work if we have symptoms. But what is the duty of the employer in all of this? Do we create policies? Do we tell people to stay at home, 100% remote? How do we navigate this, Mark?
Yeah, well, this is interesting because what we have here are very ill-defined regulatory statements, like the general duty of care that is conveyed upon employers to prevent or mitigate workplace injury and illness, right? And you don't need a specific rule that says do this for monkeypox before, as an employer, you are obligated to do the right thing to mitigate and minimize workplace spread of disease. I think this is one of the least observed rules in the history of regulation. With physical injury, it's really obvious and really easy, but with these kind of contagious illnesses, which have really only bubbled onto the radar, except in some certain industries that have bloodborne pathogen risks, these things have only come onto the radar associated with COVID. And I think the worst thing that employers can do is forget that general duty of care. I think that they need to think long and hard about what they can and should do to prevent workplace spread, which would include medical surveillance. It would include an exclusion from the workplace for the period of infectivity. Those would be smart things that all employers should do. And by the way, should still be doing for COVID, even though unfortunately many have abandoned that responsibility in recent times. There's also what's your moral and ethical obligation as an employer? I mean, should you feel good about a permissive environment that actually positively causes infection of your employees? Things like allowing people to come to work with flu symptoms, right? Why would you do that? Why would you do that as an enlightened human being, let alone as an employer with a legal set of responsibilities? But I think the number one responsibility employers have is to educate themselves, to remain current on emerging best practice, to listen for guidelines that will enable them to tackle the responsibilities that they have. And with a disease like this, which, as we've said, has been understudied, monkeypox I'm talking about right now specifically, where we don't know enough, and where the information is changing very rapidly, partly as a function of that number of cases multiplying, right? So the more cases we have, the more information we get. It would be really somewhat foolhardy of employers to turn their back on this and not have somebody specifically designated, probably within their HR team, to keep up with this, to develop some resources for information, to turn to their existing medical vendor partners and talk about how they can work, or to seek out new partners for consultative and for operational measures. That for me would make absolute sense.
And Dr. Cherry, does the CDC have anything in place for workplace actions or policies that employers should follow?
I did think I heard it's either OSHA or Cal OSHA may be working on some monkeypox medical standards for employers to basically be held accountable for. But this is very early on. I know actually Dr. Walensky from the CDC, that she's the director for the CDC. She had given a pretty impressive review of their internal review of the CDC's performance recently for COVID, and they did admit to not being fully prepared to provide, actionable information for the general public and most likely employers. We discuss this all the time. The CDC advises the general public, and OSHA kind of requires employers to perform to a certain standard for employee health and safety. And so, us here at Axiom, we look at really what's the best practice available in the medical evidence and knowledge, and then apply it operationally. But I know the CDC is probably going to be restructuring to be more proactive and providing real-time guidance for these outbreaks of polio. Just getting back to monkeypox, it reminds me of early days of COVID when we would be advising clients, and COVID was very overwhelming, but we would still hold the line of changing the paradigm of really zero tolerance of infection in the workplace. And we would say you would want everyone else in your community to be the source of an outbreak, but you be the last one. But with more rare or smaller outbreaks like monkeypox, if it would become very apparent if your workplace was actually the source of an infection. So again, you want to be the last potential source of infection in the community as your workplace.
Just to jump on that, the CDC is a population health, public health focused entity. Their mission is to identify and intervene in basically the spread of disease. They give guidelines that are for the general public. They have no regulatory focus on employers. Employers are subject to separate and higher standards. So the CDC's published guidance is the absolute minimum that you should consider adhering to as an employer, but it's not enough. And you have a duty to figure out if the CDC's guidelines are appropriate to protect you and your workforce, or if in fact you need to go further and do more. And I would be very cautious about relying upon general public health entities, whether federal or state or even local, as the primary guideline for my responsibility as an employer.
So we know that most HR leaders are really tired, really tapped out, and they don't really know where to turn with some of these things. What would you recommend to them? Is there a source or a resource? If the CDC is not the right place, if OSHA is not yet there, what would you recommend? This could be Mark or Dr. Cherry.
There are two sources of advice here. One is legal and one is medical, right? There are law firms that focus very closely on employment law and employer obligations and employer practices that they're focused on reducing liability for the employer. But reducing liability is a great place to start when you consider what your moral and ethical obligations are to protect your workforce. So that's one source. And if you have an employment law relationship with a law firm, make sure that you stay on their radar. Quite a number of law firms, high-profile law firms, offered advice, published advice during the course of COVID. And then the second one is a workplace-focused occupational health provider like Axiom, but I'm not here to sell Axiom. I'm here to highlight the fact that there are entities out there who can consult with you and help you develop appropriate preventive measures and appropriate reactive measures. And if you wait until something becomes all-consuming, you're going to be way back in the line, right? And so your risk of not doing the right thing gets much higher. So I would reach out to my preferred workplace health or workforce health partner at this point and start a dialogue about what should we be thinking about, what could we be doing.
Sure. And Dr. Cherry, can you tell me how maybe medical surveillance technology and case management could benefit?
Certainly, I think medical surveillance is obviously an appropriate medical tool, but I actually think it's a great cultural change tool. As I've thought through this for COVID, without kind of a medical surveillance a medical surveillance technology or tool that kind of gives people objective, actionable information, you kind of rely on integrity versus culture. And I think a lot of times culture can actually push out folks who, if there's not a culture of zero infection in the workplace, you can really run afoul of everyone starting to come back in like things were prior to COVID. And so you can tailor medical surveillance through an app-based technology specific for specific outbreaks or, so if it's flu season, if COVID is spiking, for monkeypox specifically, you can change screening criteria based on the disease. And it's a great tool because one of the most evidence-based and effective measures for illness and injury in the workplace and out is effective case management. There's been many, many studies on that. And so what happens is you essentially are getting the right care at the right time and you're being returned most efficiently. A lot of times people, when they're injured or ill, they'll kind of have what I call a tough guy or a tough person attitude where they just kind of are very stoic or just push through the pain. But what happens ultimately is they end up getting worse, not better. Their productivity suffers during that period, and then they may actually be out of work longer or indefinitely. And so again, case management, early intervention is as soon as you can have someone engage into the appropriate assessment is really key in having the best outcome for the employee and for the employer.
Just to be clear, because medical surveillance sounds horribly like, the CIA probing into our business every minute. That's not what it is at all. Medical surveillance is basically screening your workforce on a, hey, I've got a headache. Do I have COVID kind of thing? Mm-hmm. And what the way we do this, and other companies follow similar approaches, is we have a kind of a logic tree that says, well, okay, you've got a headache. Do you have any of these other symptoms? If you have several of these other symptoms, have you been in contact with people who have had COVID? We end up with a presumptive answer. It is likely that you may have COVID. Go get tested, go see your primary healthcare physician, and in the meantime, don't go to work, right? And it's as simple as that you're asking your employees either on a voluntary basis or on a daily check-in basis and one would be, I am symptomatic, and the other would be, I am not, and I'm not worried that I've been exposed. So one is everybody checks in every day, and another one is people who have reason to be concerned check in. The everyday check-in is way more effective because it normalized that process of thinking about yourself, your condition, your risk of infecting coworkers. It even helps people figure out, well, am I risking infecting my family, right? Am I, there's a benefit outside the workplace to knowing this stuff. So it's way more effective. But then the other one, which is on a voluntarist basis, if you have a strong culture that makes people feel responsible for their behaviors and not want to infect their coworkers, you can use the voluntarist approach as well. They both work. Scott's talk about case management, though, in this case, what most of these medical surveillance programs would lead to would be an exclusion from work until either a conclusive negative diagnosis or a resolution of symptoms such that the employee could safely return to work. And that return to work screening is the other half of medical surveillance, right? You don't want the employee back in the workplace infecting their coworkers before earlier than they should. And one of the questions that we get a lot about this is, well, God, that sounds expensive. And, you know, here's the truth. It's not super cheap, but compared to the loss of productivity and the potential liability risk and the perception from your workforce that you either don't care about them or care deeply about them, it's the cheapest way that you can possibly go about actually developing an illness safety culture and a low or zero infection workplace.
Mm-hmm.
Awesome. I love it. Okay, tell us about the duty of care for Axiom. I know that we have expanded our services above and beyond just to make sure that we are honoring the employers who are in struggle and their employees who are trying to figure out all of this infectious disease. Why do we take this consultative approach?
Yeah, that's really simple. We're trying to be the good guys, right? I mean, look, our culture says first, we start our employee handbook with a set of key behaviors, because behaviors are more meaningful than values when it comes to workplace engagement. And the number one on that list is do the right thing. And that applies to what we do as individuals, but it also applies to how we behave as a corporation in the public sphere, in the public square. And we feel that because we know, we have an obligation to share. Because we can do, we have an obligation to try to do, right? We're mission driven. Our mission is to help employees with health and injury challenges in their workplace. Well, this is what we do. It would be extremely narrow-minded and in my mind neglectful of us if we didn't try to drive outreach on these kind of issues. Same reason we're now working in the mental health space, because mental health is as much a workplace issue as contagious illness or physical injury. And we just feel passionately that businesses in the space that we're in, and I'm talking for us, but I think it applies to everybody who's in this occupational health workspace, we just have that moral obligation. It's not a legal duty of care. Our legal duty of care is over how we perform the task if we're contracted for it. But our moral responsibility is to be, you know, as Ronald Reagan put it, that bright shining beacon on the hill, the citadel, right? Our moral responsibility is to advocate strongly for the right behaviors and the right things that protect our employer clients' workforces.
Absolutely. Healthcare equity and accessibility is so important, and I'm really glad that we can do this. All right. So we do have a question coming in from a Canadian. She says, Canadian here. Hi, Alyssa. Asking for my American branches. Are immunizations in the US a state program or a federal program? In Canada, immunization programs are largely provincial run. I'm sorry.
Provincially.
Sorry, I'm having a hard time with those small letters. So tell us a little bit more about the immunization program in the United States.
So I think it's very similar to kind of our federal and state legislative and judicial structure. We do have federal guidelines that are focused through subcommittees of the CDC. So it's the ACIP. It's I'm trying to remember. I forget what the acronym stands for, but it's the organization that comes up with the immunization practices guidelines. But I do think states still have independent power to come up with at least that, but maybe more stringent recommendations. And then I think, organizations within the states actually may even have higher standards. So there is this kind of multi-layered. It can become more and more requirement based on that. So, but you do have this federal kind of guideline that's kind of the base value of what should be considered recommended.
As with everything to do with health, federal guidelines are the lowest standard that you have to adhere to. Mm-hmm. And certainly in areas like education, for example, individual states very strongly intervene in what vaccinations you have to have in order to be permitted access to public schools. There are a whole raft of these things. Some states are thought leaders in these areas. California, New York, Illinois amongst them. And others are less focused on regulation, and so don't layer on additional requirements to the same degree.
That's great, thank you. I don't see any more questions coming through. So I want to take this moment to thank you both for your generosity and your time and your expertise today. On the screen now, you'll see a survey, and that link will take you to a survey that'll give you a pulse of your culture. How are you holding up? What's your resilience of your culture like? Oh, moving through this pandemic has taken a toll on all of us, body, mind, and spirit. So if you want to take a pulse on how your culture is doing, go ahead and take a picture of that survey. And then the QR code on the right is our upcoming webinar on September 1st. It's a special prevention discussion. Suicide Prevention Month is September. We're kicking it off with this webinar, and we'll take you back to Miss Nurse Holly Foxworth to lead that exciting discussion. So thank you both for your time and energy today, and for educating everyone. You know, healthcare accessibility and equity is really important to Axiom, and we want to make sure that we continue on this educational path. So thank you so much for your time today.
Thank you, Autumn.
Take care. Bye-bye.
Bye.